What I would like to talk to you about is, I think I would describe it as an academic presentation of clinical management problems. And I know that Rambam is a large general hospital covering adult and pediatric medicine and a variety of specialties, and I wanted to address a topic that I thought, while perhaps specific to my field of pediatric electrophysiology, had interest and lessons to be learned from it that were of more wide interest and applicability and could be applied in a variety of different disciplines. The title of the talk is Sudden Cardiac Death in Young People. And the subtitle, as you see, is that how do we interpret and manage small but catastrophic risks that patients face. And in particular, this morning, we'll be talking about the risk of sudden cardiac death from arrhythmia. The objectives in brief, and this won't be an excessively long talk, so maybe there will be time for questions at the end, is to discuss a little bit about the epidemiology and the impact of sudden cardiac death in young patients, to talk briefly about what are some of the causes of sudden cardiac death in my patient group, and then how we evaluate patients at risk for sudden cardiac death, particularly focusing on the topic of one etiology of sudden death, which is Wolff Parkinson-White syndrome. And finally, I'll talk a little bit about, in a general sense, the difficulties in calculating risk of patients who don't have any evident disease, and helping them and their families make appropriate therapy decisions given their underlying illness. It's important to realize and to think about the fact a little bit that sudden cardiac death in apparently healthy young people is a very rare clinical event. In population studies performed in the United States and elsewhere, there are a variety of estimates of what the incidence of unexpected sudden cardiac death is in apparently healthy young people. But I think it would be fair to say that the consensus of these estimates is that no more than about one such event per year takes place in a population of between 100,000 and 200,000 people, which is about 100 times less frequent than the incidence of sudden cardiac death in adults, which, as you know, is primarily due to varieties of acquired heart disease. Given the fact that children have much longer life expectancy than adults, perhaps there's some compensation in terms of the total number of years lost, but it still is small in scale compared to the problem of sudden cardiac death in adults. Nonetheless, as you are undoubtedly well aware, because this is true throughout the world as far as I know, the public awareness of sudden cardiac death when it occurs in a young person is very, very high. And there's a great desire to identify at-risk individuals and prevent sudden cardiac death. And to some extent, this urge to protect children from this catastrophic and tragic event guides policy making at many levels with regards to health care and public safety. When we look at the overall annual mortality in the United States, and then this is just an old demographic chart where we actually look at the populations at risk times the actual incidence of events, we realize that the number of people who are children who actually die suddenly from cardiac causes down at the bottom here is sufficiently small on this bar graph that you can't detect the height of the bar at all compared to overall adult death rates and then apportion death rates from causes such as high-risk coronary artery disease, cardiac dysfunction, et cetera. Some of these categories obviously overlapping. But the publicity that surrounds these events escalates them to the front of the public eye. This is somebody who I'm sure that none of you are familiar with unless you lived in my city, Boston. But if you did live in my city, Boston, 15 years ago, this guy was one of the absolute stars of one of our local athletic teams, Reggie Lewis. He had an episode where he collapsed at age 23 on the basketball floor in a very public setting. And the repercussions of his death literally have echoed through the community for more than a decade after it happened. And you can probably make a slide like this by taking clippings from local newspapers in Israel. This is over a year, over a year's period in Boston, just clipping out the headlines and leading storylines of the type of attention that episodes of cardiac arrest obtain in children. Now think for yourself what the papers would look like if every time an adult with coronary artery disease or non-ischemic cardiomyopathy died, if they merited a headline story in the paper. There wouldn't be room for anything else. But looking at these types of headlines, one would surmise that this is a very common problem, and certainly it elevates the perception in the minds of parents around the community that their child may in some way be at risk for such an event, even if statistically we know that's not likely. So what we get into in a case of thinking about this problem is a battle between reason and emotion. And what I mean by that is that we use both sides of our brain when we evaluate risk. And as physicians and other healthcare providers, it is our duty to help patients and their families interpret risk in a way which makes sense to them. The rational side of our brains tells us that risk is an analysis of a likelihood of some future damaging event, and we make some numerical calculation of that likelihood, and then we multiply it times the amount of damage that we think it's going to cause. And when we do that for all different types of risks, we can identify which are the important risks and which are the less important risks, and how much attention we should pay to each of them. The emotional side of our brain combines all kinds of fearful feelings, anxiety, dread, uncertainty, a loss of control, and as many of you have children and families, you'll know that these are particularly compelling decision-influencing factors when we think about our own children. So what is it that we try and do when we want to think of a clinical strategy as physicians now that would help us to prevent sudden cardiac death, sudden cardiac arrest in children, or to prevent them from injury from it? First and foremost, we need to identify which patients would presumably be at risk of experiencing this type of event. And basically, I can tell you there are three major streams which contribute to those group of patients who we evaluate as being at increased risk. Is first, many patients get sent in and referred for minor prodromal symptoms. They may not even be prodromal in the sense that they may be unrelated to whatever risk they bear, but for some reason a child comes to the attention of a pediatrician, or God forbid, a pediatric cardiologist, or even worse, a pediatric electrophysiologist. They may come in because they've had a fainting spell, they're dizzy, they have chest pain, palpitations, very nonspecific symptoms, but then they get tested in one way or another, most frequently an electrocardiogram, and a diagnosis is proposed. Another possibility is there may be another family member who has suffered a cardiac arrest. This is a much higher yield group of patients. And within the current time when we have genetic screening and certainly other phenotypic ways to identify patients who share certain risk attributes with deceased or injured family members. This is another way we identify patients who need to be treated. And finally, in many areas, the military, sports, in the United States now, there is a strong lobby to screen people before they're treated with drugs for attention deficit disorder, but mass screening programs may often identify people with abnormalities which were otherwise undetected. Once we have selected a group of patients who we think may have some increased risk, and we'll get more into this in a moment, what that risk might be, then we have to decide how to provide some risk mitigation, how to provide them with prophylaxis against this event, which hopefully is not worse than the event itself. In the case of arrhythmic diseases, this may be in the form of specific therapy, such as a catheter ablation, placement of an implantable defibrillator, or administration of medication or some combination of those things, or it may involve lifestyle modification, limiting the child from performing certain types of activities or taking certain sorts of medicines that we may think could increase the risk. What are the common underlying causes of sudden cardiac death? This list is actually my very good friend. As a pediatric electrophysiologist, when I'm dealing with people who are quite fearful and concerned about risk to their children, the main thing that they fear is the unknown. And I can say to them with some certainty that the list of diseases which cause cardiac arrest in children is not infinitely long. In fact, it's quite short. So we only have to test for a certain panel of potential causes. Now, this isn't comprehensive, but this covers the great majority of children who do have some risk. In categorical terms, these diseases fall into congenital heart disease, which, as you know, comprises many specific diagnoses, but are easy to identify. The kids have a scar on their chest, and if you get them to take their shirt off and listen to their heart, you'll know if they have a congenital diagnosis. The more difficult diseases are the cardiomyopathies, such as hypertrophic cardiomyopathy, abnormalities of coronary arteries, myopathies such as ARVC, and probably most important in terms of prevalence are the primary electrical diseases such as long QT syndrome, WPW syndrome, which I'll speak more about now, and other less common electrical myopathies such as Brugadas. So finding these patients is a little bit like searching for the proverbial needle in the haystack. I've already indicated to you how rare these diseases are. Most of the time, the people are identified for reasons unrelated to symptomatology or any specific illness and without particular risk factor. And this is one of the things that comes up relatively frequently. WPW, as you know, is a disease of the electrocardiogram. It was described in the early middle part of the 20th century by three doctors, Wolff Parkinson-White, who published a paper in the American Heart Journal about young people with paroxysmal tachycardia and an abnormal electrocardiogram. And this is the typical sign of pre-excitation with widened QRS complexes in the lateral leads that characterizes WPW. What is it? Well, the reason that people have WPW, and it occurs in about 1 to 2 in per 1,000 patients, is that they are congenitally possessed of a small myocardial fiber that connects the atrium and the ventricle. Here you see the leaflet of the mitral valve, the atrial myocardium, ventricular myocardium, the annulus fibrosus. And this tiny fiber is an extranodal fiber. It goes redundantly to the AV node, which, as you know, is the normal connection between the back and the front chamber of the heart. And here in this old paper by Wolff and Wood, they described the electrical properties of what was then called a bundle of Kent. And they noted that because it provided an accessory pathway between the atria and the ventricles, it could cause pre-excitation of the ventricle, and that also the same pathway, if it was utilized in the opposite direction, could be the substrate for orthodromic reciprocating tachycardia. Quite a remarkable set of physiologic inferences to be made from electrocardiogram and clinical observation in the 1930s, and absolutely 100% accurate as we understand the disease now almost 80 years later. So here's what it looks like when somebody has SVT. And for those of you who are cardiologists and electrophysiologists, bear with me as I address the rest of the audience who doesn't do this every day. We have a sinus rhythm here, and you can see that the QRS complexes look somewhat broad and wide, so that's the typical pattern of Wolff Parkinson-White syndrome in one lead. And here the patient has had a single atrial extrasystole. Because that comes somewhat earlier than the pathway can conduct, the conduction is through the AV node as a narrow complex, and that allows that circulating rhythm because now the activation can go backwards up the formerly blocked pathway. And you see here on the right side of the screen that the patient has gone into supraventricular tachycardia. Now, SVT is not a lethal rhythm, and we don't think that that causes sudden death in children, but in WPW there's another form of rhythm which is potentially lethal, and that's what we refer to as pre-excited atrial fibrillation. That looks like this. This is a hectic, extremely rapid rhythm, which is the result of extremely rapid atrial activation, which rather than, as it would normally be, constrained by the normal activity of the AV node, is permitted to go rapidly to the ventricular chambers through the accessory pathway. And ultimately, this type of rhythm is fast enough to induce ventricular fibrillation and is known to be the cause of sudden death in WPW, which will occur on the average. Well, I'll get to it at the bottom of this slide. So as I just mentioned, there is a sudden death risk for patients with WPW. It applies to all patients with WPW. It's because this little pathway that I've described can rapidly conduct atrial fibrillation. It turns out that when we look at a large number of patients with WPW, and in particular some of them who've had cardiac arrests, syncope, or sudden death, that there are certain characteristics of this pre-excited atrial fibrillation which are more common in the patients who died. And particularly, if we go back and we say, what's the shortest interval which is pre-excited between two beats? If that's less than about 220 or 250 milliseconds, those patients have been known for many years already to be more likely to be the ones who suffer sudden death. When we ask ourselves, what's the cumulative risk for somebody of having sudden cardiac arrest with this disease over their lifetime in population studies, at least those done in North America and most of the studies from Europe, it turns out to be a cumulative risk of about 3 or 4%, which turns out to be about 1 death per 1,000 patient years. And that's an important number, and we'll get to that next. It's also nowadays a somewhat controversial number, and we'll think about the implications of that as well. So here's just a brief case to take us into what we do about this. A 16-year-old boy who we saw in our hospital who had minimally symptomatic Wolff Parkinson-White syndrome. He happened to have Kawasaki's disease as an infant, so he was being followed on a regular basis by a pediatric cardiologist who every now and then checked an electrocardiogram. So for no particular reason and with no symptoms, he was noted at age 9 to have WPW on his electrocardiogram. And he underwent testing with a Holter and with an exercise tolerance test. And he was noted that his delta wave disappeared when his heart rate went above 110. And people thought, well, that means his heart's probably safe. He did have transient symptomatic palpitations, but no documented tachycardia. And after 7 years of being followed with this, he presented to the emergency room after 7 years with sustained palpitations. And lo and behold, I'm sorry, this perhaps doesn't reproduce all that well, but this is in fact pre-excited atrial fibrillation. I think on this particular view, the lines came out a little bit too faint for you to appreciate, but I can tell you that what this shows is a somewhat milder version of the more dramatic electrocardiogram I showed you on the last screen. So what can we do about these patients? We've now identified a kid who has Wolff Parkinson-White syndrome, and at least at age 16, for some reason, the potential to go into atrial fibrillation. In 1944, a doctor by the name of Richard Onell wrote a 2-page long paper where he talked about WPW, and in particular, he speculated on the ways that you could possibly treat this in patients. And he, would have to be considered to be the visionary of cardiac ablation. If you really look in the literature, it's hard to find anything that antedates this. He said, if we could block this bundle with a knife, with electrocoagulation, which many of you will recognize as we now call radiofrequency ablation, or by injection of a substance which kills a restricted area of tissue. Now, subsequently to this, about two and a half decades later, people began to take his advice. This is a picture of a surgeon, Dr. William Seeley, who down in the southern United States invented a surgical procedure for taking care of Wolff Parkinson-White in patients who had severe disease. And basically what he did is he would bring people into the operating room, open their chests, and he would lift the heart from the pericardial sac, and they made for him an electrode which he could wear as a ring on his finger over his surgical gloves. The wire came back off the table and they connected it to a polygraph where they could amplify and measure the electrical currents, and he would put his finger underneath the AV groove on the right and the left side, and they would compare the timing of electrical activation in the ventricle locally to the timing of the electrocardiogram. And from that, they could infer, by looking at earliest activation, exactly where the pathway was. And once he had an idea if it was on the right side of the heart, the left side of the heart, the bottom of the heart, he actually could dissect the AV groove, take it apart, and then put it back together. He would have divided that tiny pathway in the process of his dissection, and then when he sewed it back together, the scar would be electrically non-conductive and the patient would be non-pre-excited and cured after the procedure. Now, we don't do it that way anymore. Actually, on rare cases, we do, but for 99% of the cases, we don't do that anymore. We use a device which was invented by an engineer named Will Webster. And Will Webster is probably known to some of you here because he is the Webster who in Biosense Webster. He invented the first deflectable catheter, the first catheter that could be used intentionally for other than diagnostic reasons back in 1990. And this is what it looked like then. And the business end of this catheter is right down here at the end. You see there are some electrodes for recording signals, and the one at the end is somewhat bigger than the ones before it. So what we do is, this is a fluoroscopic view of the heart, obviously, and the white dots and lines in it are ablation catheters. And this is kind of a typical pattern for if we wanted to do an ablation on WPW, we would set the catheters up something like this. And when I look at this screen, I would like you to see it more this way, which is we put the catheters in known anatomical locations of the heart, and those locations are related quite specifically to the arrhythmia, to the rhythm-generating structures of the heart, and we can extract signals from those places and make very strong inferences about exactly where the pathway is located. Once we do that, we can use that tip of the catheter, and by injecting radiofrequency current, we can cause resistive heating. Nowadays, we also have catheters that can freeze tissue if we think that cryo techniques would be preferable, and that destroys an area of myocardium under the surface of the tip of the electrode. By heating it, we know that when we heat myocardial tissue to a temperature of about 49 or 50 degrees Celsius, we cause permanent depolarization and ultimately result in electrocoagulation of the tissue. And this is what it looks like. This is a very old slide, but it's the best one we ever made, I think, as far as showing this is concerned. You have, again, the pre-excited rhythm. Here we see the voltage rising and the power going up to our radio frequency, from our radio frequency generator through the tip of the catheter, and you see immediate loss of the delta wave. This time it's not because we've blocked it and we're going into SVT, but it's because the heating at the tissue has actually caused permanent elimination of that of that arrhythmia substrate. What's the safety and the efficacy of this procedure? Dr. Boulos mentioned that I've been involved with the Pediatric and Congenital EP Society. This is a group of some 250 subspecialty physicians from around the world, and in the 1990s this was called the Pediatric Electrophysiology Society, and we ran a registry and recorded the results on more than 7,000 procedures performed in the 1990s of this type, and we got some good data. Our success rates were greater than 90% overall, even as we were learning the procedure. The likelihood of recurrence was low. The risk of serious complication was very low, and the risk of death, probably about 1 patient in 1,000, and bear in mind this was during our learning period. Between that and other studies, we can develop some numbers, and the reason it's going to be useful to know these numbers is, remember, the point of this talk is how do we assess what decision we should make for people if they have a child with this problem. How do we calculate the risks and benefits? So it helps if you have numbers to be able to allow you to do that. If we think the risk of death from WPW is 0.1% per year, 1 per 1,000 patient years, and we think the likelihood of long-term success of an ablation is 85%, the likelihood of death is 0.12%, the risk of complications is about 8%, then we can use those numbers to make some calculations. And in particular, we can use a technique called number needed to treat. And this particular calculation uses the likelihood of death from the procedure versus likelihood of death from the disease and the likelihood of cure to say, well, how many patients do you need to treat in order to save a life? And it turns out that it obviously depends on your parameters. If we assume that the annual risk of sudden death is 0.1%, it would suggest that in those patients we would need to treat as many as 140 patients to save 1 life. If the risk is 0.5%, we maybe only have to treat 20 patients. If the risk is 1% per year, we have to treat maybe only 13 or 14 patients. Well, when we know that type of information, we can begin to get into an approach that we would describe as cost-effectiveness analysis. Not where we say doing a procedure or taking a certain course of therapy is right or wrong in the abstract sense. We can just say, well, how much does it cost us compared to other medical or surgical decisions we could make? If we assume that in the United States that the total cost of this procedure is $36,000 and the complication rate is 5%, well then, if the death rate is 0.1% per year, that means the cost per life saved is $5 million, and we're going to have 7 adverse events in other patients. If the death rate is 0.5% per year, the cost per life saved is much less, and only a single adverse event. And remember, in these particular lives, we may be saving 1 life, but we may be saving 50 or 60 years of that life. So one thing we can do is we can say, is there any way that we can risk stratify these patients? Because risk stratification means that we're trying to selectively choose patients who have a higher risk of sudden death. I've already shown you if the risk is 0.1%, it's quite expensive approach to taking care of this risk to do ablations on everybody. If we can increase the risk by a factor of 5 or 10, and we have a group of patients who are much more likely to suffer this problem, then suddenly it becomes much more efficient for everybody. So this is just the general principle of screening and risk stratification. We want to make the soup thicker, if you will, so that when we reach in, we're more likely to get something good. There are ways that we can do that, and it relates to something which I've already mentioned before. I told you that the narrowness of the time between consecutive beats, what's so-called the shortest pre-excited RR interval, and I'll just point out this funny acronym SPERI because it comes up on a later slide. The shortest conducted interval between 2 consecutive beats turns out to be a relatively good predictor using retrospective clinical data of those patients who are going to have sudden death. If somebody has a shortest pre-excited interval, which is relatively long, the number is 300 milliseconds, they're probably pretty unlikely to experience a cardiac arrest. But if there is a high-risk patient, you might see that they're, based on at least the data that's available to us, that instead of their risk being 0.1% per year, it may be as high as 0.6% per year. When we look at actual populations of WPW patients, it's a little bit hard to see this number in reality. And the reason is that even 0.6% per year, and certainly 0.1% per year, is a small number compared to the actual amount of clinical data that we have available to us to look at. We're talking about the large studies are groups of about 109 patients, 986 patients of follow-up, and even though many of these patients have high-risk findings, they really have no mortality to speak of, so we don't really know whether or not these patients are doing what we expect them to. Similarly, the tests that we have available, non-invasive testing such as exercise testing, I'm not going to explain this data now. It's perhaps a little bit technical for this talk. It doesn't help us to discriminate all that well. So the predictive value of these types of tests that we can do non-invasively is quite limited. There are many false positives and negatives, but overall we can probably increase the risk value of the group a little bit. So with that, let me talk about another case which may be a little bit more interesting than getting into the details of what I have to admit is pretty arcane subspecialty literature. This is another patient who I took care of, 14-year-old boy who plays American football. He's a big fellow. He had occasional episodes of palpitation, and it wasn't clear why, but he saw a cardiologist, and he turned out to have Wolff Parkinson-White syndrome. He had an exercise test, and we couldn't make the delta wave go away, and we called that non-reassuring. The delta waves stayed. So again, this is his electrocardiogram showing pre-excitation. We brought him to the cath lab, and he underwent an intracardiac EP study and an ablation, and this showed 2 pathways, and one was successfully ablated, but one was extremely difficult. And he had a prolonged procedure, which it was actually involved so much fluoroscopy that he developed acute radiation dermatitis, which I'll show you in a moment. He continued on medication and continued his athletic participation. This is what his skin looked like 12 weeks post-ablation. He had had 85 minutes of fluoro exposure. Ultimately, we were able to ablate his pathway using other techniques, but I would say this is an example of somebody who had a minimally symptomatic disease discovered serendipitously and suffered quite a significant acute interventional complication as a result before his pathway was finally eliminated. Contrast that with this case, 6-year-old girl who had a murmur. That was the reason she came to her cardiologist for evaluation of a murmur, and the cardiologist made an incidental finding of WPW. And her murmur was because of a trivial subaortic membrane. She was a little kid, The cardiologist who was taking care of her was a very fine senior cardiologist, and she had planned to do these exercise tests and Holters at age 6 as soon as she got a little bit bigger. And again, very unremarkable pre-excitation. This was the outcome for her. She died playing recreational soccer at age 7 in front of her school and in front of her parents. So obviously, this is an extremely rare event, but it points out just how incredibly high the stakes are in this case. And it's a very difficult process to decide whether or not one should take these patients to the cath lab for an interventional procedure, which in itself holds risks as well as benefits. I want to finish up by talking about risk assessment and how we deal with situations like this a little bit more in the abstract. I just want to telegraph to you before it gets to it that I don't have an answer for this. I think the interesting part of clinical medicine is how many things we don't have answers for, but how carefully we can think about them all the same. A term that I think is very important for people who are interested in difficult problems like this is equipoise, clinical equipoise. And it has a rather specific definition in clinical research. And what clinical equipoise is clinical equipoise is the state of a lack of consensus among reasonable and qualified expert clinicians as to the optimal management of a specific clinical problem. It's not the same as saying that somebody isn't entitled to have a personal opinion or an idea about how a problem could be treated or approached. And that idea may be something that is quite a strongly held belief by an individual, and it's not wrong. It may even be that an individual physician takes different strategies for different patients based on how they assess the problem. The reason that equipoise exists for many of the problems that we take care of, and certainly the problem of asymptomatic Wolff Parkinson-White syndrome in children is one of these problems where we're at clinical equipoise, is that the data to inform decision-making may not be gathered yet and presented to the community. It may be that we won't get that data because there are insufficient resources allocated to study the problem, or it may be that it's impossible to study the problem because there are a limited number of patients or they're inconveniently distributed in a way that they can't be assembled in a sufficient number to answer the question. In a way, you can think of this in terms of classifications of clinical indications and evidence. And you have heard of class 1 indications for various treatments and therapies where consensus exists among experts that the treatment is indicated. My partner, Dr. Ed Walsh, summarizes class 1 indications are, you're a fool if you don't do it. Class 3 indications, you know, are where everyone agrees that treatment is not indicated, and Ed would say, well, you're a fool if you do treat someone under those circumstances. And of course, in class 2, where expert opinion is divided, the message is, we're all fools. And nobody really knows the answer. And this is, of course, the state of clinical equipoise. When we look at the indications for ablation in children, there's only one class 1 indication where there's uniform consensus among everybody that you have to ablate a child. If you have somebody who has had aborted sudden death or an episode of syncope and they're known to have a high-risk pathway and you fail to ablate that child, that's wrong. You have to do that. Everything else, every other indication for ablation, a procedure which I will admit we perform very frequently, is a class 2A or a class 2B indication. Well, why do families choose to have an ablation? You know, they've had scary episodes of tachycardia where their kids have ended up in the hospital. They may have bothersome symptoms. They may be averse to taking medicines, have complicating medical or lifestyle issues. But importantly, they always receive the advice of a trusted physician before they go into this, because that's the gateway to the cath lab and to the ablation procedure. And they go in through that doorway to the ablation valuing certain things slightly different from what we value as physicians sometimes. What families fear is death, complication, or exposure to unknown risks. And I think it's fair to say from my experience and from many of the people here who are pediatric specialists dealing with sick children can confirm this, that sometimes the fear of adverse event is much greater than the desire to have a problem treated. So it's important to help families with informed clinical decision-making, with a real sensitivity to this concern and to these types of issues. It's important that you understand the specifics of the clinical situation and that we build a partnership in decision-making with families with a balanced discussion of evidence, which really acknowledges the degrees to which we are uncertain about the right course. And that can be sometimes quite quantitative or sometimes a little bit more storytelling as appropriate to the individual family. And finally, it's very necessary after this conversation is had with patients to have it again if necessary and to check that they really understand the information that you're presenting to them. Just to finish up, there are a couple quick biases that we need to understand affect families' opinions about disease and the risk to their individual child. And these can actually be categorized, and it's interesting to think about things. Availability bias means people overestimate a risk where they've heard about it before. So those newspaper headlines tend to increase people's perception of risk. Compression means that people, as a rule, tend to overestimate small risks and underestimate large ones. They miscalibrate. They may have an excessive notion of how reliable and accurate our information and knowledge of the risk is. And they tend to be optimistic and underestimate risk as it applies specifically to oneself. Finally, they're more tolerant of risk when they feel that they're choosing to undertake a risk as opposed to when a risk is imposed on them from without. For instance, if you're a driver or a passenger, where do you feel more at risk in a car? Obviously, when somebody else is behind the wheel. And in general, doing something is less scary than doing nothing. Fortunately, and I won't go over this in detail other than to say that an interesting study was performed of pediatric electrophysiologists and asked them what they actually told patients, what numbers they gave patients. And we don't have to run through this list. Suffice it to say, over the majority of pediatric electrophysiologists, what people tell their patients is reassuringly close to what the numbers actually represent. And finally, it's our fundamental duty as physicians to be a trusted advisor. We need to promote patient autonomy in decision-making by giving them as best we can the notion of informed consent, and that balances the present risk of disease and the potential for future benefit. But we have to recognize that we're constrained by deficiencies of our own collective and individual knowledge and the differing abilities and desires of patients and their families to understand. So I'll leave you with this thought. If it was your child, what would you do? It's been a pleasure to speak to you this morning. I've really enjoyed it, and if we have time, I'd be happy to take any questions.